evening, everyone. This is Upasna Mukherjee. I'm a genetic counselor. It is my absolute pleasure to welcome you all to today's insightful webinar on the small genes, big impact, reimagining the policies, diagnosis, and care for the inherited metabolic disorders in India. We are honored to be joined by a truly distinguished speaker, Dr. Gauri Krishna, today, whose contributions to the pediatric genetics and metabolic medicine have been both pioneering and deeply compassionate. Dr. Krishna is a UK-trained pediatrician and a clinical geneticist with over a decade of specialized experience in inherited metabolic and neurometabolic disorders. She holds an MPhil in medical genetics from the University of Cambridge and is a board-certified pediatrics and metabolic medicine from CCT UK. Currently, she serves as a consultant in pediatric genetics and metabolic medicine at several leading institutions in Bangalore, including the St. John's Medical College, IGICH, Rainbow Children's Hospital, Cloud9 Baptist, and Peopletree Hospital. Her research spans lysosomal storage disorders, organic acidemias, and transplant outcomes in the metabolic diseases. She also has led international clinical studies on the Niemann-Pick disease, AEDC deficiency, X-linked hypophosphatic rickets, and so on. More than credentials, what stands out in her dedication to deliver empathetic, accessible care for children. I'm sure we are going to get good and such insights from her talk today. Welcome, Dr. Gauri. We are thrilled to have you with us today.
Thanks, Upasna. That was a long introduction, but thank you. So good evening, everyone, and thank you for sparing some time to I think, have a useful discussion on where we are at with inherited metabolic disorders. I've now roughly been practicing just over a year after relocating back. So my experience may not be very comprehensive in terms of what is available, but from my experience, these are sort of the important points that I wanted to put across, especially looking at policy and diagnostic care pathways in inherited metabolic disorders. So from the perspective of what we're going to discuss today, I wanted to look at 5 key points. One of them was just what are inherited metabolic disorders, and I'm sure a lot of you are aware of it, so I was just going to briefly touch upon that. What I'm more interested in sort of discussing or teasing out with a lot more intent is the policy landscape in India, diagnostic challenges and innovations that we need, gaps in patient care and support, as well as visions for future in terms of recommendations that we can give. So IMDs are no longer in practice, rare in practice. They're rare individually, but they're quite common collectively. The burden is significant, especially when left undiagnosed or untreated. So today's talk will cover diagnosis, newborn screening, acute care integration, and what policy change should look like. This is an old sort of hypothesis. It's been around for ages, and it highlights what exactly inherited metabolic disorders are. So they're a group of genetic conditions caused by mutations in genes responsible for enzyme production involved in the body's metabolic pathways. When these enzymes are deficient or malfunctioning, it leads to accumulation of toxic substances or deficit of essential compounds in the body. And this was described really well with Garrett's hypothesis, where if you look at it, when A is becoming B and B needs to become C, if there's a deficiency at that point, then you have substrate excess, that is a buildup of B and A, which then leads to formation of a toxic metabolite, which can manifest with various presentations. So importantly, they are monogenic disorders affecting either enzyme or transporter function. And when I say monogenic, I mean one gene is responsible for the enzyme or making the transporter. And deficiency or defects in these genes can cause deficiency in the enzymes or the transporters. Most are autosomal recessive. Of course, there are some exceptions which can be X-linked, but most are autosomal recessive, and they present predominantly in infancy, childhood, and sometimes in the neonatal period. Globally, approximately the sort of caseload is 1 in 1,500 to 5,000 births. And in India, we don't have precise epidemiological data, mainly because we don't have a national registry, and we don't have universal extended newborn screening. But studies previously have estimated sort of 1 in 1,200 to about 2,000 births. But I think this is a real underreported, underrepresented figure because we don't have the diagnostic infrastructure or, as I said, the extended newborn screening. And of course, we are an endogamous country with high degrees of consanguinity. So what are our examples of these conditions? So the few ones that I have mentioned are maple syrup urine disease, which is caused by a deficiency of an enzyme that is broken down, that breaks down proteins to make certain amino acids, and that leads to sweet smelling urine and a lot of severe neurological damage. There's been a lot of sort of case representation within Kerala and Maharashtra. So we need to look at epidemiological data to see whether these areas are, have a higher incidence of this particular condition. The other one, which is common and which was sort of the base standard where most of the other inherited metabolic disorders were described, was phenylketonuria. It's caused by a deficiency of phenylalanine hydroxylase enzyme. I think this is predominantly a sort of Caucasian IMD, and we know that high levels of phenylalanine cause intellectual disability if not detected early. And I think the important thing for even the next condition I'm going to discuss is if picked up early, the outcomes are really good. So they're rare but treatable with early dietary intervention. The other one, which is X-linked, which is sort of different from the autosomal recessive disorders that I was talking about, is ornithine transcarbamylase deficiency. And this is an X-linked disorder. So what it means is that girls have 2 X chromosomes, so their presentation can be variable. They could be asymptomatic or could have some degree of hyperammonemia. Whereas boys who have only 1 X chromosome, if they carry the mutant gene on this particular X chromosome, can lead to severe hyperammonemic crisis and death. Now, the cases are increasingly identified, especially the urea cycle defects, of which ornithine transcarbamylase deficiency is a part of, in urban NICUs, although the sort of management protocol still remains quite fragmented. So we just want to finally look at what I mean by sort of fragmented, underrepresented thing. We know that India's birth cohort size is 25 million births a year and must be more. This is from one of the papers I picked. And high rates of consanguinity in certain regions. The absolute number of IMD cases is substantial, and it definitely warrants systematic policy attention and expanded newborn screening programs. So what should a GP or an ICU clinician do when there is sort of a high suspicion that this might be it? The most important thing is do some immediate actions, correct the hypoglycemia, make sure that you've given them 10% dextrose. Remember to collect some blood ammonia and lactate, and if possible, a filter paper blood spots if you have them. If not, at least collect 1 sample in EDTA and 1 in lithium heparin extra. Stop protein feeds if you suspect hyperammonemia, if they're encephalopathic, and if possible, seek urgent metabolic consultation. And the recommended sort of first-line investigation in any case are simple and are available in most public sector as well as rural areas, which is recommended first-line investigations of random blood sugar, a blood gas, ammonia, serum lactate, ketones in the urine, plasma electrolytes, and of course, infection markers. I just wanted to highlight a case vignette. So this is a 4-day-old male neonate brought to a rural ICU with recurrent seizures, poor feeding, and lethargy. No fever, no birth asphyxia, and blood sugar on admission was 42 milligrams per deciliter. So the fact that there were seizures, hypoglycemia, without infection or asphyxia, poor feeding and lethargy in the first week, and mum had previously reported early neonatal death in a previous sibling, and this was a consanguineous family. So these should set your alarm bells ringing, and sort of the immediate action should come into play at this point. Another case vignette, 2-day-old term neonate presented with vomiting, rapid breathing, poor feeding, drowsiness, low blood sugar, had lots of acidosis, metabolic acidosis. Ammonia was not available locally. So again, within the context, consanguineous parents, no infection signs, acidosis, hypoglycemia, a lot of vomiting in early neonatal life. Again, red flags. So the first case was a problem with fatty acid oxidation defect, and proper feeding with the biochemistry serves well for the child. And the second one turned out to be an organic acidemia. Again, remove the protein and make sure that you're correcting the acidosis and giving enough energy. So the key rule is any neonate or child presenting with unexplained seizures, hypoglycemia, acidosis, or encephalopathy should be suspected for IMD, especially if there's a family history of unexplained neonatal deaths or sibling deaths. So just moving on to, so we've got all of this happening in the background, and we have got people probably working in silos. They've picked up these cases. Some people are affordable. They're able to, send off more investigations, admit the child for longer, for better care. But some children may not be this lucky. And what we then need is a systematic policy change. So I thought we could just look at the NPRD and IMD care in India. So the national policy for rare disease was released by the Ministry of Health and Family Welfare, and it's India's official framework to address the needs of individuals affected by rare conditions, of which IMD is one of them. So the key features include disease requiring one-time curative treatment like bone marrow transplants, diseases requiring long-term or lifelong treatment with relatively lower cost, and diseases requiring lifelong treatment with very high cost and no definitive cure. So these are the three key features. So financial support provisions of up to rupees 20 lakhs for eligible diseases under select categories. I don't know if the money has gone up, but this was from the last document I had seen, through crowdfunding and government assistance schemes. And of course, establishment of centers of excellence across India for diagnosis, treatment, and research. Now, within this context, the problem was there is no clear demarcation for inherited metabolic disorders. So while NPRD broadly recognizes rare disorder, it sort of fails to give specifically identify inherited metabolic disorders as unique, actionable category. And many IMs, though individually rare, collectively form a significant disease burden due to treatability and early onset in neonates. So there's no structured national newborn screening guidelines under the NPRD framework, which sort of misses a very critical preventative opportunity for early detectable and treatable IEMs like the fatty acid oxidation defects, organic acidemias, amino acidopathies, which is all of the examples that we're looking at. So financial support provision focuses mainly on diseases requiring one-time treatment or high-cost therapies, but they completely neglect lifelong dietary management and biochemical diagnosis, which is really essential for monitoring, maintenance, and good outcomes in IMDs. The other thing is there are state disparities. We're a huge country. We can't set off, and Department of Health is under is a state legislation. So there's a real issue with state disparity. So there's considerable disparity in rare disease care and screening programs across Indian states. Kerala is one of the few states with some government-funded public newborn screening program. Maharashtra has a limited pilot newborn screening and metabolic care initiatives, which is largely driven by private-public partnership. Tamil Nadu and Karnataka have excellent, I think, newborn screening extended, which is offered in tertiary setups as well as in corporate setups, which I don't think has infiltrated statewide in the smaller tier 2, tier 3 cities, towns, as well as in the rural areas. And in the other states, there's really no formalized newborn screening or state-supported IMD care pathways. So what does this lead to? It obviously leads to inequitable access to early diagnosis and care, disparate health outcomes based on your geography, and absolutely missed opportunities for early life-saving interventions in most regions. So why does this matter? So without dedicated IMD inclusion in the National Rare Disease Policy and uniform newborn screening, many treatable metabolic disorders remain undiagnosed until irreversible damage occurs. And they typically present in in crisis in ICUs. And diagnostic challenges, and we discussed earlier. So if you've got a child, a neonate presenting with persistent hypoglycemia with no clear etiology on initial routine metabolic panel, which can only be confirmed through an extended panel, which may be unavailable locally, you miss a real opportunity of early management, because this is a highly responsive disease, and you have completely normal outcomes if picked up early and treatment is initiated within like 24 hours, and we can send off extended sort of panels if possible. This baby, unfortunately, in the vignette had seizures and significant gliosis. By the time we got to, the baby came to a tertiary referral center and we got to the diagnosis. So that's such a missed opportunity. And these are real diagnostic challenges, because when you think about it, this was completely preventable, treatable, if there was universal newborn screening. So the other thing I wanted to discuss is, obviously lots of people are sending off genetics as an easier option, because it seems to have infiltrated the country with a lot more robustness than biochemical testing. And I just wanted to add the caveat and a sort of red flag that if you have a negative result, it doesn't necessarily rule out inherited metabolic disorders. And this is really important to think about and imbibe when we are sending off genetics without doing due diligence with workup from a biochemistry point of view. And biochemistry is not replaceable in that sense. It is invaluable. And I appreciate that sending at least genetics makes sense, that even if you're not able to do much for this one, you have some information maybe to help the next one. But I think we need to move away from that thinking a little bit as well, and try to see how best we can treat what we are given with at this particular point in time. So one of the things is obviously incomplete or limited gene panels, why we may get a negative result. Most commercial or hospital-based panels test for fixed number of known mutations. Some IMDs are ultra rare or regionally specific, and their causative mutations may not be included in standard panels. Indian-specific genetic variants may be unrepresented or underrepresented in global panels. For example, child with SCOT deficiency, which is a type of inborn error of metabolism leading to ketolysis defect, may test negative on a whole exome sequencing, because this particular gene is GC rich and may not be covered, or there may be deep intronic mutations that we're not picking up on whole exome sequencing. So the takeaway is, I don't think we can definitely move away from biochemical testing and just send off genetics as sort of the final part. The other issue is variants of uncertain significance, and I'm sure lots of geneticists, if they're here, would echo my sentiments of the absolute frustration when you see something like this, because its clinical relevance is uncertain, and we have to do a lot more other things in order to gather evidence. And again, it falls back to your biochemistry. Of course, you're going to do parental segregation and so on, but it still goes back to your phenotype as well as biochemistry in order to try and classify these variants of unknown significance. And in IMDs where rapid intervention is crucial, the US findings can delay appropriate care if relied upon too rigidly. The other issue is, polygenic and multifactorial influences. And I've recently had a child who sort of highlights this. So there are some metabolic phenotypes which result from interactions between multiple genes or between genes and environmental factor. So a single gene negative result would not capture this complexity. A neonate with severe hyperammonemia may have no identifiable monogenic cause, but a combination of mild variants in urea cycle genes and transient physiological factors still need to be addressed, because it's significantly toxic to have hyperammonemia. And this crisis may occur again and again in view of the fact that we still have a negative genetic result. So misdiagnosis without biochemical correlation is a real danger. So metabolic disorders often manifest functional enzyme deficiency detectable through biochemical tests through various ones, especially plasma amino acids, urine organic acids, and TMS. Sole reliance on genetic tests without biochemical screening can lead to missed or delayed diagnosis. And one of the things is MSUD might be missed on a rapid gene panel, but confirmed by elevated branch chain amino acids in blood. So it's really important that we don't move away or digress from biochemical testing just because genetic testing is more easily available. And why does this matter in India? So we have limited access to expanded gene panels or exome sequencing, or even lack of specialist centers to interpret complex genetic results. And in the absence of comprehensive newborn screening in most states, you don't really have a backup of screening and early intervention. And of course, financial constraints in any resource-limited country is always going to be one of the problems that we think about. So a negative genetic result should never definitely rule out IMDs in clinically suggestive cases. The clinical signs, the biochemical markers, careful longitudinal observation, they all remain essential in resource-constrained settings. So I just wanted to also now move on to care pathways and ICU coordination in inherited metabolic disorders. And this is really important because when you think about it, we are really, and I think this is one thing that's constantly hitting me after working in the NHS, that it's a very silo practice here, unless you're part of large institutions, which is fair enough. But I think the collaboration, integration, communication has to improve, and I think there is a degree of I don't want to call it hoarding, but sort of it's a hoarding where you're not ready to part with something despite knowing that it's probably beneficial that we discuss a little more and share our knowledge, and that's really important. I always think of this one story my mother used to say. There's a story of a huge cauldron with long spoons, and all the information is in this cauldron, and it's like the amrita, and you need to get it out, and lots of people are clamoring around the cauldron with their long spoons. But once they dig out the amrita, they can't feed it to themselves because of the spoon being long, and it only works if you dig it out and dig out the amrita and feed another person, and the other person feeds you, and that's how it works. And I feel that is where we should be heading in terms of care pathways and ICU coordination in IMDs as well. So we know that they land up in very non-specific ways of seizures, hypoglycemia, lethargy, vomiting, encephalopathy, acidosis, even a sudden cardiovascular collapse. But what are we doing from then on? In these cases are usually admitted to general neonatal pediatric ICUs. Staff are skilled in critical care, but they may not be completely attuned to managing metabolic crisis, and especially things like MSUD, OTC deficiency, mitochondrial crisis go unrecognized initially. And what usually begins is a symptomatic treatment, which is fair enough, but without addressing the underlying metabolic cause, we're not going to be able to solve the problem on our own. And one of the examples is a neonate who presents with seizures and hypoglycemia may receive anticonvulsant and dextrose. But if there's a fatty acid oxidation defect, unless you're going to scale it up in terms of what you need to do for the baby, we may not be able to get to the end result quickly. So there is a need for standardized emergency protocol across sort of ICUs, even rural healthcare setups, public sector, private sector. It's really important that there are standardized emergency protocols where we're looking very clearly at addressing things in a time-sensitive, protocol-based intervention. So hypoglycemia requiring immediate glucose, hyperammonemia, protein restriction, making sure you're giving enough energy with glucose, access to certain specific medications like benzoate, sodium benzoate, and dialysis in very severe cases of hyperammonemia. Same thing for metabolic acidosis, judicially correcting the metabolic acidosis, and if required, dialysis with stoppage of protein feeds. And seizure management, where we're looking at avoiding hepatotoxic drugs or those contraindicated in metabolic disorders when we're treating them. So the need for standardized emergency protocols, it's sort of largely absent in most Indian hospitals, but of course, I'm not talking about the corporate setup, which has a lot more access to resources and information. So the initial things like the protocol should include initial stabilization steps, first-line investigation, a metabolic red flag checklist, and contact points for tertiary metabolic centers. And again, that goes to, are we really looking at building tertiary metabolic centers? So, so I was mentioning, there's a specialty communication gap. So the effective management of IMDs require coordination between pediatricians, neonatologists, critical care specialists, biochemical lab teams, geneticists, and metabolic specialists. Of course, there's a limited number of metabolic specialists, and that goes back into training. And I think that is something that is required, because you will, if you're working in intensive care, you will never not meet a inherited metabolic disorder. You will, and that's how these cases present in any case. So in order to upskill our ICU specialists, we do need to start introducing training programs within intensive care programs as well. We have poorly defined referral pathways. I don't even think there is a really hierarchical, sensible referral pathway, and that goes back to government or state-funded regional metabolic labs and genetic services, because only then will we be able to monitor ourselves, audit ourselves, improve our quality of work, and have a hub and spoke sort of environment to help overcome the communication gap. And of course, all of this leads to delayed decision making. And I think the other thing I really think we should be looking at, because I think what COVID opened up to us was teleconsults. And in order for teleconsults within legislation to be really robust and have ability for us to use our information, and again use hub and spoke to disperse it to a wider catchment area. So the end result of all of this is experienced, children with reversible IMDs. I think that's a really important word. The reversibility of these IMDs. They often experience diagnostic delays and suboptimal care, increasing the risk of mortality and permanent disability. So from my perspective, I think this is really important. This is urgent, because many IMD crises are treatable with simple, timely intervention. Lack of protocols and poor cross-specialty handovers lead to avoidable deaths. Integrating metabolic protocols into ICU emergency checklists can save lives, especially in settings without specialized teams. So this is really sort of my take-home point. So I wanted to see what our current care system was like. And to me, what it appears to be is there's no structured newborn screening. Neonates land in general ICU during metabolic crisis. Clinicians often manage symptomatically without suspecting IMDs. And again, this is not a sort of a reflection of any particular state or city. It's a general thing, because obviously now I've started seeing children from other states as well, and this seems to be the general story. And clinicians often manage symptomatically without suspecting IMDs. There's limited access to metabolic specialists or genetic counselors, and the lab's not equipped for urgent metabolic investigations. This leads to families experiencing delay in diagnosis, expensive unstructured care pathways, and the fact that the NRDP does not actively guide metabolic disease care pathways. So that leads to delayed diagnosis and higher mortality with permanent disability. I mean, what I'm hoping that will happen is that when we have an ideal integrated care ecosystem, and we have to build the ecosystem, is that we have national newborn screening programs for IMDs inbuilt within the public health infrastructure, ICUs equipped with metabolic emergency protocols and training modules, designated regional metabolic centers with lab and genetic expertise, rapid biochemical and genetic testing access, policy-backed financial and dietary support for lifelong care, integrated referral pathways between ICU, geneticists, labs, and centers of excellence, and family advocacy groups and awareness campaigns supporting early care-seeking behavior. So that's really important. The final bit, I think ORDI comes into picture with the last bit, and we need more advocacy groups and awareness campaigns supporting early care-seeking behavior. So I think from my perspective, it's really important to expand NPRD to designate specific actionable strategies for IEMs. Currently, groups of IMs are under general rare disease category without actionable disease-specific pathway. So what's needed is metabolic disorders section, standardized diagnostic treatment and referral protocols, financial coverage for acute management and lifelong care for specialized diets and medicines like sodium benzoate, integrate IMD case registries and surveillance systems to estimate true disease burden, and that will help us to mandate periodic policy updates based on emerging data, and then we can look at new therapies as well. So this is going to be, I think, my swan song. It's really important that early diagnosis of IMD is critical, and most present acutely within the neonatal period. Make expanded newborn screening mandatory in all tertiary and public sector NICUs. At minimum, screen for treatable life-threatening IMDs such as MCAD, MSUD, OTC, glutaric aciduria, galactosemia, and biotinidase deficiency. And if possible, to have TMS in terms of having regional centers and point of care ammonia testing. And I think point of care ammonia testing is invaluable, and I'm not sure we're anywhere near that. And of course, we build a national newborn screening database with uniform reporting protocols. So invest in regional metabolic centers for excellence. I think that's really important. Currently, India has a few metabolic centers equipped for advanced diagnostics, emergency metabolic care, and patient follow-up. What's needed is we get state-supported regional metabolic centers linked to medical colleges, equip them with advanced biochemical testing labs, genetic counseling and diagnostic services, medical metabolic emergency support teams for ICU consult, dietary therapy units, and family education service, and enable these centers then to act as training hubs for ICU teams and neonatologists. And, obviously, I do need to talk very briefly about public awareness and advocacy campaigns. Early diagnosis is impossible if families and frontline clinicians are unaware of these conditions. So a public awareness campaign is invaluable in bringing communities together. And that's really important because we live in no longer live in isolation. We're in a technical bubble. Everything is connected. Everything is in our fingertips. Everyone has a smartphone. So public awareness is critical, and obviously need to use very strong social platforms dedicated to helping people understand, identify these particular conditions, so that early treatment and intervention can be launched. We need to launch a national state level campaign about signs and risks of IMDs, particularly targeting new parents, frontline healthcare workers, develop a very simplified clinical algorithm and ICU-ready protocols. And all of this does need public-private partnership. It cannot be done in isolation, and that's really important. Engage family advocacy groups and patient support groups to help destigmatize rare disease and push for policy reform. So this is really important, and this future vision matters because without focused policy, early detection systems, and coordinated care pathways, India risks losing treatable neonates to preventable metabolic crisis with severe health, financial, and emotional tolls on families. And that's something that I've now been privy to quite an extent when I see these families really struggling. Implementing these changes can reduce IMD-related infant mortality, improve long-term outcomes, and strengthen India's rare disease care infrastructure. So that sort of highlights and ends my talk. If you have any questions, please feel free to ask.
Thank you so much, Dr. Gauri. This was really, really an eye-opening, very insightful. We are talking every day. Kerala, we have started, even I was very closely attached with certain metabolic newborn screening programs, and we know the importance right now. So I thank you so much. This is very insightful. I think it will help our advocacy groups also to understand the need for the policies right now. We all are fighting right now in India, understanding the importance right now. I would ask the attendees to please post your questions in our QA section if you have. I think there is one question. Mr. Vikas Bhatia has asked why newborn screening is not mandatory in India, which diseases we can cure by liver transplantation. I think this is very important when we talk about the management of IEMs and IMDs. I guess we need to understand, apart from the dietary management, what can cure the diseases also certain times. So would you like to take this question, Dr. Gauri?
Yeah, so why is newborn screening not mandatory in India? It's a question I've been trying to answer. It
Yes.
should be. Universal newborn screening has been implemented in every developed country since 1971. And we are still lagging. We're not anywhere near universal newborn screening. Forget extended, not even the sort of the basic ones that need to be done. That's not done either. Extended obviously includes metabolic conditions that I've been talking about. I think one of the things is there is a real lackadaisical approach to preventive health care in our country. We're not coordinated well. We don't speak to each other. There is a real, I said, an issue of hoarding. We don't come together often. And, even discussions like this will end up having ego hassles. I think we need a real move and push. And I think people think of doing extended newborn screening as a money-making scheme. And there is a lot of mistrust because there is poor awareness campaigns, poor communication. I think if doctors start, especially the pediatricians and general physicians who come across these people first, you have a longer rapport with them. I think you have to get behind universal newborn screening, and only then we will effect a policy change. I think we shouldn't, a country like India shouldn't be talking about costing anymore. We're not a poor country. We have unfortunate corruption and poor trickling down effect, but we are not a poor country. We are just poor in our reforms, our thoughts, and we've got lots of bureaucracy. I think fighting the bureaucracy is a completely different topic, but yes, newborn screening should become mandatory in India. There is no question of why.
Absolutely, no doubt. And I second you. I think we all second you here. I think there is a very good point Mr. Bhatia has raised. Is there any role for gynecologist? I think this is very important to
Very important.
sensitize the parents. Yes.
Totally. And I think, as I said, if you're a primary care physician or you're the obstetrician or you're the, pediatrician who's known the family's great-grandfather, everything, if you're the first point of contact, I think awareness starts there. If you start talking to them about newborn screening, that preventive healthcare is far better than trying to treat it secondarily. And I think gynecologists play a very important role in sensitizing parents and constantly talking about, because newborn screening is like the screening they do for, increased risk, the nuchal translucency, all of those parts, which is, within your RCO or your obstetric guidelines in terms of what you do when a woman is pregnant, from her folate to her scans. Newborn screening needs to be primed, I think, starting from there. So that's an excellent question. And yes, absolutely.
And so as a genetic counselor also, we have tried this for in many parts of India right now. The basic thing that parents, basically the new parents, they basically trust their gynecologist more than the pediatrician at that point. So if they give that insight that no, after the birth, you have to do all these things for the child, even in the private sector, it is not done. For all the setups, it is not done because the pediatrician is not telling only the basic conditions. Certain times now thyroid and the bilirubin and everything is happening with the hearing test. That's a good part, but the rest of the things are not happening. So that sensitization is there. I have one question for you because you have already been working in NHS also. So what are the family education like strategies you found effective in the other part of the world, which is important for the family education? And when we talk about the health service providers like our ashas and AMNs, what are the policies or what are the training sessions? Because we are right now isolated way in some co-pilot projects. We are also trying to train them for rare diseases. So what do you think that family education, how little changes in the ASHA's workers curriculums and all we can actually impact this identification of early IMDs?
So one of the things that obviously the gynecologists are very important, but once the baby is born, there are health visitor contacts. So, a health visitor goes in, a midwife goes in, does home visits. So the home visits are really critical. And even during those periods, the questions are again asked about, family history, consanguinity, neonatal deaths. And if those are red flagged early, taking filter paper and getting those blood spots really early, and then the baby seeing within 24 hours of the ASHA worker or the health visitor seeing the baby, if the baby's not putting on weight, vomiting, crying, all of these red flags immediately get upskilled to getting seen by a local pediatrician very quickly, and a filter paper is taken at that very point. So they carry the lancets with them so that it's done, and the baby is very quickly then seen by a pediatrician or a general practitioner, a GP, even not even a pediatrician. So I think those sort of care systems really need to be included in order to try and make education more important. And I think within the context of education, we need to run a government-sponsored sort of evaluation awareness program that needs to come on the television. That those are the things that we need to get down to,
Yes.
because everybody watches the news, the horrific news, the channels screaming in between. Instead of putting ridiculous ads, if the government starts running campaigns for making sure that you get extended newborn screening, but that can only happen when policy changes, where even with the rare disease policy, metabolic disorders need to become part of the public health infrastructure, and extended newborn screening needs to become mandatory. So we're still in building infrastructure and incorporating IMDs within the rare disease policy to have an integrated care pathway. So I think we're still in taking baby steps, but it's sad that we're still taking baby steps because the West has been doing it now for more than 50 years.
And we have the capability. That is the
I am no longer, I'm no longer ready to listen to us playing victim.
Yes,
No.
absolutely. This is not the time for Indian people to
No.
say we are victims.
No.
We are equipped.
Yeah.
We have manpower.
We have manpower.
So manpower.
Totally. I mean, I think if you look at the vaccination for COVID,
yes,
that is a great example of where there's a will, there is a way.
correct. Very, very nicely said. And there is another very good point Dr. Shalini has right now, that there are a lot of, infant deaths are already happening, right, which are not investigated properly. So how much forensic medical support here is required? I think that gives an answer that we have to set up more fetal autopsy centers.
Absolutely. And Dr. Shalini and I have worked together in the NHS, and she was my senior there, and we both had a case of a child brought in with SIDS a very long time back. And that baby went to have a metabolic autopsy, and then a very long chain fatty acid oxidation defect was diagnosed in that baby. So she also, so I think it was the first time that we came across a child with SIDS that went on to, and this was a long time back, obviously we both are much older, went back to, us doing metabolic autopsy and then finding the diagnosis in this child. So even I think awareness of doing metabolic autopsy, and I always say that, if you forget to collect anything, do a suprapubic aspirate, get one urine, get a filter paper. That's all you need.
And now we suggest that please try to save the DNA. That will
But even as I said, if you have nothing else, if you have a filter paper, you can do a suprapubic aspirate or put a catheter in, get the urine out. Those two are enough to make a diagnosis, because you can send it off for biochemistry, you can send it off for urine organic acid, you can send it off for DNA. So that's all you need. So the awareness that you need only two things, even in a metabolic autopsy.
Wonderful. Very, very insightful, Dr. Gauri. And there's another question also, if the diagnosis using prenatal screening will be helpful in early detection.
So we can't do prenatal screening. You can't take amniocentesis and diagnose unless you have a genetic, a previous baby, you have a confirmed genetic diagnosis. You can't do antenatal testing for early detection, because you can't use amniotic fluid to detect any of the metabolites being abnormal, because we don't have standardized levels for that. So the only way you can detect antenatally is if you have a confirmed genetic diagnosis of a metabolic question.
I think that's all right now we have. If anybody has any further question, I think this is really, really helpful. And Dr. Gauri, we would like to, we are looking forward to work with you more in collaboration further from ORDI, I guess. And if Dr. Aaron was here, Dr. Naresh is here, Dr. Shalini, I think we all, if we can come and communicate with each other from the different parts of our country, and we'll start building our own chain to provide the best benefit to our patients, I think that would be the great thing.
And I just wanted to say, one of the pioneers of newborn screening, Dr. Radha Ramadevi, has just said she has seen. And I think, I hope in our lifetime it happens. We've got to keep pushing. And I think the first step I think ORDI needs to do with us is push RDP to include IEMs as a special category for lifelong diets and treatment. And that is something that we need to have a well-defined goal towards. That's really important. That will affect policy change for mandatory newborn screening.
Very, very, very important point, Dr. Gauri. Thank you so much. If anybody has any further question, then you can please post us. Otherwise, I think, okay, Dr. Shalini has also asked, I think you have already answered it. How do we change the current practice of not investigating this for the benefit of the next children? So,
again, I think what's really important is if you have a critical baby in ICU, and you don't have access to a metabolic center, a geneticist, or a specialist, at the very least, think metabolic, collect a filter paper, ask DNA for storage that doesn't cost money. And even if it does, it's minimal money. So that at some point, if the baby passes away, we have something to go back to. And that awareness needs to come from starting from the gynecologist to the general practitioner to the pediatrician, because the ICU is a very intense setting.
Right.
It's very difficult to make yes/no decisions there. So I think the process starts maybe even from the patient advocacy groups, that they talk about, what happens if the child is not going to do well. So even from a gynecological perspective, that's when you start sensitizing them, the parents, about why it's important to do newborn screening, why it's important to find answers, because if we don't have answers, we are never going to be able to help the family in any shape or form.
Very true. And another question which came out earlier also, Mr. Vikas was asking which diseases can be cured by liver transplantation. If you can just give some insight on the treatment pattern.
So MSUD is one of the things, because if we screen, find it out early, MSUD have orthotopic transplantations. MSUDs do really well with liver transplants. There are some glycogen storages. Some of the urea cycle defects have good response to liver transplantation. So early diagnosis is key. And all of the ones have talked about are, treatable with dietary intervention. So once you have a degree of metabolic control, the idea is to go on to liver transplant, and it is curative.
Yes. Thank you so much. I think for the cases, I just would like to add on that for the cases where the child is no more available or the child death has happened, carrier testing nowadays plays a thing to understand a vital role to understand the recurrence risk also. Though there is a chance of dealing with the VOCs in our population, but I think the geneticist can help with better understanding the disease and the phenotype which is happening in the family. So carrier screening is also essential, maybe certain times when we have some kind of family indication there. Yeah. Thank you so much. I think that's all from our end, Dr. Gauri. Thank you so much for your wonderful time and insight, and you're very kind to give us this opportunity to listen to you. We would be really looking forward to work with you more in the future. Thank you so much.
Thank you.